Good afternoon, everybody. This is Dr. Kachikian from the Black Hills Regional Eye Institute, and this is a case where we are doing an IOL exchange. In this patient, the three-piece acrylic IOL was giving significant positive dysphotopsia. It is a three-piece IOL in the capsular bag, and so we're going to exchange that for a three-piece silicone IOL that we'll place in the sulcus. We've created a side port, injected some preservative-free lidocaine for comfort. Patient's doing very well. And then what we're going to do is use viscoelastic to fill the anterior chamber, and we will create our main incision. Also place an additional side port to allow for access to the IOL. There's our viscoelastic. Now, one thing you do want to do is fill the anterior chamber, but not so much that it makes it difficult to get under the edge of the capsular excess. In general, I think that three-piece IOLs are a little easier to remove than a single-piece acrylic lens because there's less scarring around the PMMA haptics, and there's no terminal bulb, so the lens can rotate more easily out of the capsular bag. We've just made a 3mm keratome incision. That's a little larger than our standard phaco incisions of 2.4 or maybe 2.75 millimeters, so depending on what you're doing. But I plan to bisect this lens in the anterior chamber and then pull it out in two pieces. And with the 3mm incision, it will still be self-sealing, but I will be able to easily get the pieces out with minimal trauma to the wound. We've gotten some viscoelastic now under the edge of the capsular excess. There wasn't too much scarring from the IOL to the capsular excess there, so we were able to get the viscoelastic underneath. And the nice thing about these the haptics on a three-piece lens is that there's not a lot of scarring in the periphery of the capsular bag to the haptics, and the haptics can often just rotate out. As I mentioned, with a one-piece lens, especially if you were talking about like an Alcon one-piece lens, they do have those terminal bulbs, which keep the lens in place and help with centration, but for lens exchange, those bulbs can be difficult because in the periphery, in the fornix of the capsular bag, the terminal bulbs tend to get scarred into position, and then if you're doing an IOL exchange, they're difficult to remove. Now we've gotten the viscoelastic cannula under the lens, and you can see this polypropylene haptic is just kind of rotating nicely out of the capsular bag. I would say with a three-piece lens, probably what's most difficult is that the haptics are very springy, and so they want to stay in the bag. So you do have to kind of rotate them out, and if you don't rotate them out completely, they tend to then regress back to their original position. And so that's why it's helpful to have the Sinskey hook to grab the edge and then pull that first haptic completely out of the bag. Now what we'll try and do is rotate the second haptic in a similar fashion, just kind of rotating it out of the fornix, getting the first edge of it up over the capsular bag, and then continue to rotate it into the anterior chamber. I'm always careful not to pull or tug too much because you cannot see what is going on in the capsular fornix, and the last thing you want would be to create some sort of capsular tear that is going to let vitreous forward or prevent the placement of your IOL. Now in this case, since we are planning to place the new lens in the sulcus, theoretically peripheral capsular tear wouldn't prevent that, but it's best to avoid it. Here we are. Now we're going to get the Sinskey under that second haptic and rotate it out just over the edge. Perfect. So now we've got our IOL in the anterior chamber. The capsular bag is intact, and now I'm going to rotate the lens such that it is in a good position for cutting and removal. My preferred technique for cutting is really just to place an adequate amount of viscoelastic both beneath and above the lens to allow cutting with forceps. And we will use the MST forceps to cut the lens, and I usually will create a countertraction with a second instrument. I think that's probably one of the most important components of cutting the lens is the countertraction or the instrument that you use to provide countertraction. If you don't have MST forceps, sometimes Van Ness is adequate in a pinch in satellite offices. During surgery, if I've ever had to remove a lens, that is typically what I do. I use a Van Ness to cut the lens at the wound and extract it that way. Again, it's that countertraction that becomes the most important because with these acrylic lenses, when you cut down with the scissors, it wants to move away from you. And now there are varying techniques you could use. Occasionally I will try and cut the lens into 3 pieces, but if you can stay in the midline, and these are 6mm optics, so if you can stay in the midline, you have a 3mm incision, and you cut right down the middle, then each half of that lens should come out fairly easily. Occasionally, if one half is bigger than 3mm, you can pull it out through a 3mm incision. The lens will just fold. You do want to try and make sure and minimize trauma to the wound because you'd like it to be a self-sealing wound if possible. So there we've got that lens cut in half, and that's pretty good in half. Maybe that piece on the right is a little bit larger than the left, but what we are going to do is we're going to pull that first piece haptic out, and since that seems to be the smaller piece, it should come out pretty easily. And then if the second piece doesn't come out, we can always cut it more. So we get it to the incision, and then I'll use a 0.12. If you start really pulling by the haptic's going to break off from the optic, and that's not ideal. So you can use the haptic a little bit to get it kind of to the mouth of the incision, and then you want to use a 0.12 on the optic to get a good purchase on that optic and pull it out. And there it's pulled out with minimal trauma. Now we're going to do the same thing with the other half. You do want to make sure that if you start pulling with that polypropylene haptic, that the edge of the optic isn't caught in the incision, because you'll be pulling and then you'll be distorting your wound and tearing your incision. So a little more viscoelastic here, and then we'll use the Sinskey to get good positioning. And we will again grab with 0.12 forceps. You could again also use the MST graspers, but I find that tooth forceps provides a better purchase, and with those MST instruments, if you're not gentle with them, they're going to break. You're going to wind up sending them back to the manufacturer to get them fixed or repaired or replaced. And so they will work in this situation. Even the scissors, if you're cutting through a thicker optic, you might find that after a procedure or two like this, all of a sudden the tips of the scissors don't meet. It is always good to know, that's a good point, that it's always good to know what type of lens you're trying to remove and even the power, so you can decide what type of scissors is best. Obviously, a low power lens is going to be thinner, it's going to be easier to remove, and depending on the material, like if it's a Acrosoft material, it cuts a little bit easier than some of the material from AMO. Now what we're doing is removing our visco. Place viscoed in the eye, it's in the capsule bag, it's kind of everywhere in the eye at this point, and I don't want to have any pressure spikes. I plan to refill with ProVisc before inserting the new lens, and so now I'm just kind of using a BSS stream to liberate any of the stuck viscode either in the capsule or in the in the angle. And once I feel like we've gotten all that viscoelastic removed, we will inflate the sulcus and the capsular bag with Provisc. When we put the lens in, depending on the symptoms that the patient is having, we may want to place the optic either in the anterior capsular axis, so kind of a anterior or posterior optic capture, I should say, or we may want to just place the optic in the sulcus. In this patient, given that their main symptom was positive dysphotopsia, I elected to place the haptics in the sulcus and do the anterior or posterior optic capture. Now here we have the B&L Softport Li 61 AO lens. This is a silicone lens that has been shown to have a very low incidence of positive dysphotopsia. We're going to place it. It's going to fit very easily through the 3mm incision, and we are going to inject and get the initial haptic, or that first haptic, in the sulcus, and then the optic will open up very quickly because it's a silicone lens, and then we can place that second haptic right into the anterior chamber and then position it using a Sinskey hook. I don't like to force that leading haptic too far into the sulcus and tear any zonules, and so I just like to place that second haptic manually. Now we will work to get to our anterior or posterior optic capture rather, and get that lens positioned. That lens seems to be very secure and very well centered with the optic capture. You will notice that there now is a very tiny tear in the capsular axis right at the location of the incision. So we will be careful when removing the Provisc to make sure that that does not extend. I think that just happened when trying to place the optic through the capsular axis in the capsular bag. Now we will get out all of our Provisc, be gentle with the iris of course, and try and get some of the Provisc out from behind the lens, but remembering to be gentle because I don't want that tear to extend. It's unlikely to be a problem with the lens and the sulcus, and nevertheless, the smaller the anterior capsular tear, the better. So we use some BSS to both seal the incision and make sure that the remaining Provisc has been removed. Again, just a stream of BSS into the angle and trying to kind of angle it behind the lens as well. As you'll see, we'll liberate some of the Provisc from behind the lens while not allowing that anterior capsular tear to extend. If you look kind of closely, you can see swirls of viscoelastic behind the lens that are being freed up. And again, the main goal here is just to prevent any pressure spikes or distension of the bag where the visco may be. There's some more visco behind the lens being liberated, just in a gentle manner. For cases like this where I do use a lot of viscoelastic, either Provisc or Visco, I tend to give the patient some Diamox, at least one, post-operatively, just to mitigate any increase in pressure that might occur. But it does appear that we've got most of the viscoelastic out, and so we will seal up our incisions and make sure the eye is of reasonable pressure. And in this case, this lens exchange did eliminate the positive dysphotopsia for this patient, and she would like us to do the same procedure on the other eye. All right, thanks everybody. Hope you have a great day.